for joining us today. My name is Sonia Castañeda-Cudney, and I am here today with my colleagues Ebony Williams, who is sharing those slides, Bex McFife, and Martine Giri Souza to introduce you all to the work and the purpose of Corvus Care Collective. Corvus Care Collective is a research, training, and policy initiative with the mission to increase access to research-supported, trauma-informed tools and approaches for providers seeking to deliver equitable, culturally humble, trauma-informed care with the purpose of preventing harm. Our work is rooted in reproductive justice across the lifespan, trauma-informed care, and decolonization. Corvus Care Collective grew organically out of talking about our individual work with one another. In doing that, we discovered that our work, as different as it is, shared the common goal of making sure that people can feel safe in accessing care that they need. Our name Corvus comes from the genus classification that includes crows and ravens. Our collective identified with these birds for a few reasons. Symbolically, crows represent transformation, adaptability, resourcefulness, wisdom, and bravery. Crows are known for their collective memory and strong community, but they also carry the negative perceptions of being loud, dark, scary, and even bad. We found that this is similar to trauma-impacted individuals seeking care. We're often labeled as difficult, non-compliant, or even scary. You may be familiar with stories online about people who meet crows and ravens with curiosity and care. These crows have been documented bringing gifts to and remembering those who are kind and caring to them. And we understand how care, curiosity, and other trauma-informed approaches can lead to mutually beneficial relationships centered around trust and collective well-being with people who may sometimes come off as loud and scary. We see this to be the key to delivering care to care seekers, specifically for those impacted by trauma. For trauma-impacted individuals, a huge barrier to accessing care is fear of being harmed or reharmed while seeking that care. Corvus Care Collective acknowledges the power dynamics that exist in everyday interactions when a person attempts to access care. We each individually and collaboratively work to show care providers how acknowledging and working within these dynamics can establish a path towards safe, deliberate care provision that allows everyone to access care when they need it. Corvus Care Collective brings our work and research together in service of promoting a culture of awareness and increasing access to care, especially for people living with trauma. For the rest of our time today, we are each going to briefly introduce you to our individual work. Our session will close with an opportunity to ask questions, and we'll leave you with a way to get in touch with us if you want to learn more. I'll lead us off today. Like most people who work in the reproductive health and mental health advocacy spaces, I came to my work out of my own experiences. I survived a traumatic twin pregnancy and birth where I was not listened to. Medical negligence led to the death of my infant daughter, Lucia, and I am a fortunate survivor of perinatal mood and anxiety disorders. I dream of a day when all people who can become pregnant are listened to, cared for, and treated with respect. In the meantime, I hope that the ReproPad, a tool that I created with an amazing interdisciplinary team in 2023, can help people who can become pregnant and experience a mental health emergency have a voice in their reproductive care that incorporates their mental health care needs. Most people are familiar with medical advance directives to make decisions for their medical care ahead of a medical emergency. A psychiatric advance directive is the same kind of planning, but around a person's mental health needs. PAD stands for a psychiatric advance directive. ReproPad stands for a reproductive psychiatric advance directive. This is an advance directive or a planning tool where you can specify a person's reproductive health history and preferences along with their mental health care history and preferences for care. A repro is like a blueprint that any care provider can easily follow and that any healthcare advocate can refer to understand an individual's care preferences and decisions during the perinatal period and at the time of birth, even if that person is experiencing a mental health emergency or incapacitated. With the amazing guidance of a PADS expert, Lori Hallmark, you can check out her TED Talk. Our team created a template to document a person's reproductive and mental health care wishes in one place. By making the template easy to complete for the individual and clear to understand for care providers, we thought that the ReproPad could help prevent the trauma of having decisions made for people without their input by medical providers during an important and sensitive time. The ReproPad is currently available as a printable template that anyone who can become pregnant can complete. It was designed originally in English with clear, non-medicalized language for ease of comprehension. We do have plans to digitize the template and translate it into other languages. You can learn more about the ReproPad at my session today at 1 p.m. Pacific and 4 p.m. Eastern. Next up, Martine will tell you about her work and how she came to it.
Thank you so much, Sonia. Hi, everyone. My name is Martine, and my work is deeply rooted in my lived experience. From the time I was 4 until I was 11 years old, I experienced severe sexual abuse at the hands of an older cousin. When I disclosed my abuse at 15, years of living in survival mode had already taken a serious toll. Once a vibrant, athletic young woman, I spent much of high school bedbound, moving between therapy and medical specialists. Time and time again, I was only left feeling dismissed. It often felt as though my trauma and my diagnosis of complex PTSD were used to explain away my symptoms rather than to understand them and give context to them. Already conditioned to living in a constant state of fight or flight because of the abuse, having to fight to be heard in medical settings felt familiar, but it was never acceptable. That was my experience for years, with very few exceptions. My own desire to understand trauma led me to pursue a bachelor's degree in social work. I initially planned to become a trauma therapist, but my work with youth in residential and community mental health settings only deepened my existing frustration with how our systems approach trauma. So in 2021, after nearly a decade of that frustration, I reached out to a physician who had been an ally in my care since 2013, an endometriosis specialist practicing trauma-informed care, actively practicing. My email, though slightly chaotic and coming after 10 p.m. on a Tuesday night, asked one central question that was burning at me. How do we increase providers' capacity to truly understand trauma and practice care that reflects that understanding? That question and his response helped set me on the path that I'm on today. 5 years later, here in 2026, integrating trauma-informed care into the fabric of medicine has become my professional mission. I've worked alongside Bex with Boston Children's Hospital to develop trauma-informed pelvic exam standards, which Bex can talk a little bit more about. And during my MPH program at Boston University, that's Master's in Public Health, I partnered with the Fenway Institute here in Boston to publish a policy brief and implementation plan advocating for the required integration of trauma-informed care into medical education and competency standards across the trajectory of the curriculum. As the founder of AUTUMN, or the Alliance for Universal Trauma-Informed Medicine, I incorporate both my personal and professional experience to bring a personalized, holistic, and comprehensive consultation service to medical organizations and providers, working to make trauma-informed care the standard of care, not just a specialty. Because while providers are navigating increasing systemic barriers and pressures, patients are often navigating systems that unintentionally harm or re-traumatize them. My goal is to bridge that gap by offering practical, accessible ways to implement trauma-informed care into everyday practice, while also advocating and working towards the structural changes needed to truly support both providers and patients. This work is what connected me to Ebony originally and led to the creation of the Corvus Care Collective as you see it today. Our work is grounded in the belief that trauma-informed care is not just a set of practices, but a product of meaningful relationships and collaboration, and is an essential step to creating a system where survivors are not just treated, but truly understood and cared for. We see a critical part of that work as acknowledging the context in which providers operate, unpacking the culture within our medical system, and supporting provider self-reflection. Bex, who I have had the tremendous honor of working with for nearly 4 years now, will speak more to that process.
Thank you, Martine, and thank you, Sonia. My name is Bex. Incorporating my story and identity to my work is an approach that I share with my brilliant colleagues here. I research liberatory care, and I also work towards embodying it. I have a background as a sex educator, and even as I've also become a medical sociologist, the core of what I do is always sex, gender, and health education, embodiment education too. Being outwardly gender nonconforming and excited to discuss it is one such public service I offer. I like to say I'm professionally queer. In this increasingly hostile political climate, I also say with pointed pride that I am professionally transgender. I put my body on the line in another way too, or to be more precise, on the exam table. For over a decade, I have worked as a gynecological teaching associate, or GTA, which means instructing medical and nursing students how to perform pelvic, speculum, and breast chest examinations by also receiving them. This is to say that I regularly invite a small crowd of students to gather around my body and look upon me as a light shines on my uncovered genitalia. That students regularly have fingers in my body while I coach them towards my cervix, uterus, and ovaries. The goal is to have a responsive and expert patient be the one in charge of teaching healthcare providers how to do these sensitive exams in ways that work for a wide range of bodies, identities, and histories. We teach trauma-informed practices that are actually useful for everyone to know, so I like to share a few here. For one, a patient can choose to sit up during a pelvic exam instead of lying flat on their back. A patient can be the one to insert the speculum themselves if it's too triggering for a provider to do it. And every one of us can ask to follow along with a hand mirror. It can be really meaningful and beautiful to see your own cervix. I've researched and published about this job, so I have data to back me up when I say that doing this work helps prevent future trauma and helps even the GTA themselves heal from their own traumatized experiences in healthcare. So this work is pretty niche, I know, but as I've pursued advanced degrees in sociology for you don't want to know how long, I've been able to connect even niche things to larger structures and values and histories. What Mills calls the sociological imagination is the ability to zoom out from the smallest interaction to the larger systemic and historic macro forces, which in turn shape our daily experiences. There's one force in particular I want to invite you to think about, and that's biomedicine. It's okay if you're not a healthcare provider. Stay with me. When I say biomedicine, I'm referring to the sprawling multi-billion-dollar industries of healthcare under capitalism, but also biomedicine as a scientific framework and, as you see here, as a cultural expression of values. A long, dark, patriarchal, white supremacist, and capitalist-informed history has led us to where we are today and still impacts us. The way we think about our own bodies, minds, and experiences are influenced. I list some of the main tenets here: reductionism, or breaking everything down into small decontextualized parts, the cleaving of mind from body, and prioritizing masculine, rational mind over feminine body emotions, and the supposed objectivity of truth. Take as an example, most of us have this experience filing insurance claims as a provider or a patient. Can you see how it's connected? We're isolating diagnoses from the larger context and the social experience and person. We're categorizing mental health as separate and usually less important than physical health, and insisting often that varying or contradicting experiences are all purely objective. Biomedical culture is the water we're swimming in, and my goal in this work is to help people notice it and how it's impacting us as a first step towards working together to make it different. Because I think we all here know that care can be far more caring and equitable and trauma-informed, and it can be liberatory. And Ebony Williams can say more on this.
Hello, all. I'm Ebony Williams, and I'm a licensed marriage and family therapist. I am a trauma specialist. I'm a child sexual abuse survivor and a mother of two. Um, my worlds merged professionally and personally when I became a parent. When I started going through that whole reproductive journey, and in working with other survivors who are parents and navigating postpartum, navigating parenting, navigating family planning, I had a new type of realization of just how big the gap is in care for survivors who are going through this specific part of their lives. And as someone who dealt with postpartum anxiety, who dealt with the ways in which CSA shows up in the parenting journey and really not having anyone to talk to about it, I realized that there was something there. There was something that needed to be done in addition to the ways in which I was made well aware of how care across those journeys can really impact the mental health of survivors. And that just trickles down. And so in 2024, Cactus in Bloom was created in order to do two main things, which was to fill that gap in care that survivors experience from anywhere from routine appointments all the way through the many different phases of parenting, and to not do it alone. And the second piece was to do the thing that many survivors sit up at night really wondering about is how do I keep my child from experiencing the same thing that I did? So we work to disrupt intergenerational cycles of childhood sexual abuse. And we know this is a systemic problem. And so we have to include everyone. Everyone's invited to the table. And that means care providers, so doing training, consultation, and support for providers on how to reduce trauma and re-traumatization. We have a podcast, Be the Bloom. All these lovely people, Sonia, Bex, and Martine, are guests on Be the Bloom, for providers to learn from folks in their field and folks who are not about what are some best practices. We support survivors through thought partnership that many survivors sit alone with many different challenges. We talk about it. We have a perinatal and infant care course. We have lots of different ways in which we are making sure to directly build community in this time that can be so isolating. And lastly, we know the impact of this. The impact is being able to parent more presently. It's being able to parent in a place where shame and silence don't have the dominant role, because we know that when violence is present, some of the tools of violence is shame, and that leads to silence and isolation. And so we do a lot of work to interrupt that. That's just a little bit about Cactus in Bloom. There's a QR code if you want to stay connected with us. And all of this is the beauty of Corvus Care, right? We all bring something different. We are an interdisciplinary team that has the same heart and goal for this work. And we're so glad that we got to share a little bit of that with you all. I want to shift a little bit to recognize that we've talked about us and you all might have some questions. So we're going to open this up to anyone who might want to ask something. And then also notice on this slide, there is a QR code for how you can stay in connection with Corvus Care, as well as reach out about any training, consultation, support for yourself or for teams that you might be a part of. We'll open it up.
I have a question.
Yeah.
My name is Kathleen Sposa, and my daughter died from symptoms of PMDD. And we now can look back and see that she had this all her life. The worst came at postpartum with her second baby. She went into postpartum psychosis. Um, and then she was dealing with the monthly after she got better from that, um, until she started going into perimenopause. And that tanked her. And I think it's because she had the trauma or PTSD from what she went through during postpartum psychosis. I wonder, since this is a lifelong problem, PMDD, and crosses all phases of reproductive health, what can be done to address all that from a place of finding support? Because she got no support from mental in or understanding of the problem from healthcare providers, multiple physicians, multiple, um, and finally she gave up because she just felt she was becoming a problem to her family, and she was afraid of going back into that postpartum psychosis. So she ended her life.
First of all, I'm so sorry for your loss and thank you for sharing with us today. That's devastating. Um, One of the things that I can speak to as a survivor of those perinatal mood and anxiety disorders, is that people don't believe you. It's not well known. People are not getting training on how reproduction and our hormones interact with our mental health and well-being. And it's very sad. There are people working behind the scenes to try to incorporate, make sure that it's mandated into training for mental health care providers, to know about these specific uh, issues. But it has not been adopted yet. And we all also believe that it's important that we are one of trauma-informed approaches is to listen with curiosity and to believe the people who are in front of you. They are the experts of their own body and their own experiences. Um,
Mm-hmm.
and when that is not happening, it is harming. It's harmful, and it can make people feel very hopeless. And so I'm really sorry for that. Martine, do you want to add anything?
Yeah, and I just also want to echo thank you so much for sharing this with us today, and I'm so sorry for your loss. One of the biggest pieces of like the advocacy work that I do on my end and the consultation work is with this mission of ensuring that trauma-informed care, which, as Sonia was saying, such a huge part of that is looking at the provider and client or provider and patient relationship as a collaborative partnership rather than one where the provider has the superiority in terms of being the expert in the room. And one of the biggest things that I'm working on my end and also at the Corvus Care Collective is changing the way that we teach providers so that trauma-informed care and the pieces of that align, whether that's communication with your patient, proper screening, which is a huge part of it, understanding of the neurobiology of trauma and the neurobiology of different mental health issues and how that changes across the lifespan, making sure that that is a required part of medical education throughout the course of the education experience. So from undergrad all the way into fellowship until they actually go out into the world, to make trauma-informed care the standard, the universal standard across the healthcare system, rather than placing the burden on the patient to have to always be the one to say, hey, listen to me. You need to listen to me. Because that in and
Right.
of itself is an exhausting, sometimes demeaning experience. I've been on the receiving end of doctors who
Yeah.
have completely invalidated me. So I think that's one of the things that's a more long-term mission, but is piece by piece one of the things that we're doing. Bex and I working on the trauma-informed pelvic exam standard to make it so that it is the standard of care.
Yeah. And just to add, I think, and I know that oftentimes folks will seek out therapists and clinicians that and think that all folks have the same training or that
Right.
all folks know or will hold space in the same way. I'm a trauma specialist because my own life story, but also
Mhm.
I had to realize at some point the training I got was much different than what is generally provided. And so this is where it's really important for folks who would not know this, like who would not know all the nuances of this and really shouldn't have to do all the seeking, but really finding key folks and being able to have access to what are the questions I need to ask? What are the trainings that people have? And so yes, there is some part of sharing with folks like this information so that they feel empowered. But really, it is about what Sonia, Martine have spoken about. How do we make this everybody is on the same page and make it
Right.
not just theoretical, but about practice? How are we embodying this, living this? Because as humans, trauma is very much universal in one way or another, and how are we making it our business to do better? And so I
If
echo everyone. Yeah, go ahead.
we, no one we talk to, doctors, nurses, mental health care providers, no one knew the term PMDD.
Yeah.
No one connected the dots. So we were desperate and we were blind, had no place to go, didn't know what to do. I had an appointment for her in Atlanta with um, a reproductive endocrinologist, and we thought and dealt with hormones and thought that that would be a solution because finally we found someone that might have an answer to what was going on. We knew it was hormonal. We just had never heard of PMDD. Well, she didn't make that appointment. She died a week before because she felt that spending money on another effort was hurting her family and she didn't want to keep doing that. So from my perspective, I'm dedicating the rest of my life to finding out or helping make PMDD as widely known as PMS. And because I have two granddaughters of my own, three actually, and I would really love to know that there is a system in place to help them if the same thing occurs.
Thank you so much. Yeah. Um, I recognize the time, but I also want to point out how we're so myopic and we're focusing on the individual and the immediate thing, and then our providers aren't talking to each other and these fields aren't on the same page about things, and all of it is like based on this sort of system and structure that we have. And I also want to point out that the collective is not just the four of us, that the collective is an expansive definition of collective, and we are really
Mhm.
looking for people to work with and to join us. And it sounds like we're on the same page of where we're coming from and what we're looking to do. And it's already been beneficial to hear from you, Kathleen. And we would love to keep talking to you.
Well,
Yeah.
let me know how I can do that because I'm just getting my feet wet.
Yeah.
Great.
Well, I'm going to point all of us to the chat. Sonia has shared our email. Martine has shared the link to the survey. There was a QR code on that side, but the survey link is right here. And then I have just shared a one-pager about all of us. So there will be links on there to each of the folks' research, to contact information. So there's so many ways you can stay connected with us so we can continue this conversation. But definitely please feel free to utilize these and to reach out.
Could you repeat which would be the best for me to reach back out?
Yeah, so in the chat is our email.
What's
And
the
so
email? What's the
it's
email?
here, I'll send it directly to you.
Oh, is it hello at cactusinbloom.org?
No, it's corvus.care. Here, Kathleen, I'll send it right to you.
Okay.
corpus.care.co@gmail.com.
Yes. And then the survey at the end that Martine sent out in this link, that allows you to basically stay up to date with what we're doing, stay connected with us. And then the last one is a one-pager where you can have different links about the research that folks are talking about and the work that's being done. So lots of ways to stay connected.
Great. Well, thank you so much.
From all of you. And I think, Sonia, you wanted to. Oh, okay. Thank you all.
Well, thank you so much to all of our lovely presenters, Sonia, Bex, Ebony, and Martine. We love having you here. If you have any questions, y'all know how to reach out. And thank you so much for joining us today. We hope y'all stick around and come to look at some of our other presentations. Have a fantastic day, everybody.
You all as well.
Thank you.
Bye.
Take care, everyone.